Started. Excellent. All right, welcome everybody. This is the National Care Coordination Academy. This is our first meeting of 2022. So welcome to the new year. We're excited to kick things off with you. We have a really great day planned. And first, I'm just going to head things off to Meg so she can give a quick couple words of welcome.
Thank you very much, Heather. Happy Tuesday, all. Welcome, and thanks for joining us today. As you know, over the life of the Care Coordination Academy to date, teams have had much meaningful progress in many domains of sustainability, including organizational support for change, political will, stakeholder engagement, and financing. We're really pleased to have the opportunity to continue to hone in and focus on that topic today with you all. And we have some really exciting guest speakers and representatives from teams to share some learnings with us. We're especially excited to hear from two of the leading children with medical complexity COIN teams today, who will describe their experiences overcoming challenges, making meaningful headway in the area of sustainability, and some of their plans for the future. All of the Care Coordination Academy teams are to be commended for their efforts and for their generosity in sharing their learnings with one another and with the wider world. This is important work, it's hard work, and it really is a contribution to the world in general. So with that, I'm pleased to turn the floor over to Rich Antonelli. Dr. Antonelli will continue the welcome for you all. Thanks for joining us today.
Meg, that was so well articulated. I'm only going to add just a couple of points. So our Academy members will recall we wanted to meet you where you were. And the teams were at very different places when we first started a year and a half or so ago. And then we accepted the additional challenge of having two new teams join us toward the end of the first year. So today's discussion is not an expectation that everybody is caught up. So I want each of the teams to look at the discussion today through the lens of, gee, what are the common pathways to get to that sustainable Mother's Day card or three-legged stool that we've been talking about, with implications for sustainability, quality, and equity and measurement. And so look for common ground. Yes, every state and territory has its own Medicaid programs, but we're hoping to accomplish through the Care Coordination Academy is what are the elements that should guide each of you on your respective journeys. I'm especially excited to welcome the Wisconsin team today. That's a relationship that I've had the privilege of being connected to for nearly a decade. And I'm not going to steal even Jeff Schiff's thunder for the introduction of the Wisconsin team. But I want to assure you, Wisconsin is where it is today because they were doing some of the very things that this Care Coordination Academy has been promoting and will continue to promote. So with that, I'm going to graciously welcome everybody back for this session. Hand it back over to Heather. And today is going to be both fun and give you a sense of yes, it is possible to move things forward.
Thank you, Rich, and thank you, Meg. I'm going to go over a couple of our housekeeping slides, but first I just wanted to read a quick quote. Cheers to another year and another chance to get it right for children and youth with special healthcare needs, children with medical complexity, and their families. You might recognize the beginning of this quote. It's from Oprah Winfrey, and then I added our own spin on it to the bottom. So just some housekeeping notes. Today's meeting is being recorded. Your team breakouts will not be recorded. If possible, please try to not use speakerphone or put us on hold. We encourage that you have your microphone muted, but you're welcome to speak and put your questions and comments into the chat. But if you are not actively speaking as part of the group, please have it muted. We encourage you to rename yourself. You do not need to put a group number for this meeting, but I will show you how to rename yourself. So it includes your state team. So you can put your state initials and then your name. So that way you're grouped together in the beginning by your state for when we get to team breakout groups. The chat will be moderated. We encourage you to put questions and comments into the chat and keep the session lively. And if you're using a computer and your phone, please link both of them together. This is how you rename yourself. You can go down to the participant section, find your name, right click and hit rename, and then just put your state abbreviations first and then your name. Today's session is eligible for continuing education credits. We are approved to offer continuing education credits to nurse practitioners, registered nurses, MDs, PAs, and social workers. If you would like to request credit, what you need to do is put your information on the attendance Google Doc that Erica has shared in the chat. If your facility does not allow you to go onto Google Docs, please just go ahead and email me and I'm happy to add your information. After you do that, we ask that you complete the evaluation that will be sent out at the end of today's session. Once you do those two things, your information will be sent over to the Boston Children's CME department for processing. It can take about 2 to 3 weeks, just given the multiple Zoom conferences going on. But you'll then get an email from them that will say, fill out a couple more questions, and then you can access your certificate on the BCH Cloud CME website. If there's questions about this or any concerns, feel free to reach out to me. So this is today's awesome agenda. We're into the welcome area right now. And then as Rich alluded to, we're going to welcome the Wisconsin team with Dr. Corden presenting. And then we will have a discussion with discussion expanders, Renee Turchi from Philadelphia, Natasha McClellan, also from Indiana, Rahel Berhani from Texas. And then we will get into our team breakouts, followed by a group discussion, and then we'll come back to close everything out together. The learning objectives for today is after this session, participants will identify different methods used across care coordination programs to assess time requirements for high quality care coordination. You will understand how ongoing relationships with payers support the program and articulate how programs have identified children to enroll with medical complexity. I'm now going to hand things off to Jeff Schiff so he can introduce our guest speaker.
Hi, everybody. I am excited about today's session, and I wanted to say that this session occurred because we had I want to honor the idea that last session in November, you all did your, we called them posters, but talked about what you've accomplished so far. And a couple themes came out of that we really felt like we wanted to address going forward. The themes that we really wanted to address were really, and I heard this really loud and clear from both Texas and Indiana, and that was around the relationship to the payer, and then also from some other teams around the relationship in their own organization. And then also about understanding the level of severity of the kids that are getting cared for by your programs. So with that in mind, we had been talking to Team Wisconsin from the COIN and really had a fascinating conversation with Dr. Corden and also with his, and then he also will introduce his team. But we wanted to have him talk about some of these aspects of his program. It's hard, he's actually going to talk about the whole program, but I think what we really want to focus on here are those aspects of the relationship to the payer, the understanding of how to identify kids, and then understanding the time commitment. So, I think you'll find Tim's presentation both fascinating and also really encouraging. And I guess I would like to say that many of you have moved very far along in the time that we've known you. And I really think that this is really, this and the next two sessions, we're really trying to figure out how to strategically get everybody oriented to be sustainable and continue your efforts when as this Care Coordination Academy will have to wind down because of the grant stuff. Tim, I'm going to turn this over to you. Tim is the medical director and section chief of special needs programming at Children's Hospital of Wisconsin in Milwaukee, and we're delighted to have you here.
Oh, it's my pleasure. Thank you so much for having us. And I do want to thank the team that's with me today. Tara Bartelt is my nurse manager partner who has been with the program much longer than I have and does a wonderful job, is a great colleague. And Sarah Johannesmeyer is our research coordinator. and both of them were heavily involved in the story that we're going to tell today, as well as our friends at the Madison program at UW, Mary Ellen Bach and Ryan Collier, really great colleagues. So thank them. And I guess Heather's going to run my slides, so that's
Yep.
that's good. I have to do one thing to make sure I was prepared for something else. I had changed one, so I need to make certain that, bear with me for 1 second. And when I get to this one, I need to, okay, go that way. All right. Okay, great. Next slide, please. Yes, I have nothing to disclose except that our program and the subsequent payment plan really arose out of a CMMI grant, innovation grant, that we'll explain. So this all is really attributed to that grant funding. Next slide, please. As I acknowledged before, it's a team effort. These are all the folks that were involved, great partners. And it's really I also want to point out the payer. They were right there. And actually they were the PI for this grant. And we'll explain why that happened. But the folks listed here all had a huge hand and were great partners in making this possible. So that'll be one of the tenets of that we hope to get across today is working with the payer, working with them early and setting up a relationship. I know it's easier said than done, but it was really essential for this work to progress. And Rebecca McAtee, her ability to write this grant deserves a lot of the credit. And the other folks listed there are really important partners. And of course, the complex care team that does all the work. Next slide, please. I won't get into all the things on this slide. It's pretty simple, just to explain some things that are pertinent to today's discussion. We certainly believe in the value approach here. We're very numerator focused and getting paid for the numerator, as opposed to always trying to race to lower the denominator. I will acknowledge that it was the denominator that got Medicaid interested in us. But through our relationship over that 5-year period, they became numerator people. And so that relationship made a big difference. Some of the basic concepts we think about with value is not in conflict with volume. We actually think it promotes it. If you do a better job and deliver better patient-centered outcomes, you'll get more volume. They're not in conflict. Our own patient-centered outcome work is starting to focus more on the capability, comfort, and calm. We're definitely influenced. I'm influenced by the friends at the Value Center in Austin, who also promote this. We believe in positive sum competition, that we make everybody better if we're better. And that's where we compete, not in lowering our costs, but just delivering a better outcome for families. It also helps with, we think, definitely helps reduce burnout and improves engagement. This is what people want to do. They want to be supported in their meaningful work. Next slide. Just to touch on this briefly, it's just our aspirations. We're pretty simple. You know that it's a small but mighty population we serve across the country. But we also pointed out to our leadership. We did a financial study of what does the CMC population, children with medical complexity, mean to our own hospital. And so that's the second bullet there. It's a small percentage of our inpatients, but 10% of inpatient revenue, it's not insignificant. Certainly for the care in the PICU, it's a large portion of their revenue, enough revenue to support 6 of our intensivists. The scale that this population brings to any institution is quite large. Those 6 intensivists take care of a lot more children than just the CMC. So it's a small but mighty group, and one that's not going anywhere. None of our competitors have the tools to do this in terms of the community hospital. So we own them, and we need to really focus on, keep them focused. So we bring this to our C-suite so that we're not just a nice boutique program. This is really an important program for them. Internally, we just go by three approaches: set our purpose, what strategy activities do you need to make that purpose happen, and measure like crazy to see where you can improve. And a lot of our deliverables are process measures to the state, but we're working more and more, and most of our research is focused on patient-centered outcomes and really trying to drill down in how do we help families so we become more efficient. Next slide. Just a brief history. John Gordon started the program in early 2000. Tara came on much soon after that, and then Sarah soon after that. So they're really important people. The relationship started early on with Medicaid here in Wisconsin. They even started a targeted case management billing. It needed improvement. John published this paper that's listed there and demonstrated, granted with pre-post analysis, which has problems with regression to the mean and other components statistically, but it was enough to get Medicaid interested. They say, oh, you can save us money. So that denominator portion. ACA came along and said, we're seeking innovation. And Mary started her program in Madison, and Wisconsin Medicaid came to John and Mary and said, we want to do more of this. Let's apply for this grant. They received the money, and we'll talk about how we got to our new payment model. Next slide, please. The goals of this were increase the number of children served in the state. And the grant paid for this expansion. This is a key point. They paid for our expansion, so they know our cost. And so knowing our cost allowed them to, it becomes transparent. That's a huge factor in how do you come to a payment model? How much do you cost? They knew because they paid for the expansion, for the salaries, for the fringe. And they included our research coordinators and our administrative assistants. So it's a program payment that they know the cost of. So that was a key to getting to the payment model. You can see that it was initially planned to be a shared savings approach. This was really important that, and I credit Rebecca McAtee and Medicaid, very quickly they came to us and said, your population is too small. If we do any type of shared risk, shared savings, you're going to get creamed. And so that was, we went into this thinking, oh, we're going to do shared savings. And very quickly, thanks to Medicaid, they said, you need a population 10, 15, 20 times what you have to make that feasible. So that was taken off the table early on. And I was initially disappointed, but they were correct. Next slide, please. We'll come back to this slide again. This is sort of the denominator, the Y part. We're able to keep all of our claims data or get all of our claims data with an MOU with Wisconsin Medicaid. So all the children in our program, we have access to their total cost of care. So we still do pre-post analysis. This was done by John Gordon well into our grant. And you can see that that red line, anything below the axis is where we saved money in a pre-post analysis, and whatever is above, its cost went higher. We primarily save the money on reduced lengths of stay. That's our biggest utilizer where we save them the most. In this analysis with a full projection of full panel size at the time we did this of 700 families, this would project to a savings about $25 million a year for Wisconsin Medicaid. So the method has its problems, but the outcome was favorable enough for us to go through with our payer. Next slide, please. How did this happen? I'll just go through this pretty quickly. A lot of it was the relationship building with Medicaid. We met with them weekly for 5 years, 2 hours every Friday to review the program, review the number of enrollments, all the people we were onboarding to get to the more children that we projected we'd get to. They wanted to know, and then they all were interested in outcomes. They started looking at outcomes pretty quickly. So we had the ability to talk to them for 2 hours. It's amazing relationship building. We also shared stories. And this program started to become their program when they started hearing about the stories. And then they shadowed us. They'd come and they'd spend time with us. And it really allowed us to them to see that it was not just a payment for service, but they came face to face with who they were serving. And this made a huge difference. Next slide, please. The model of care, we're a primary care, tertiary care partnership. We enroll patients throughout the state in northern Michigan, northern Illinois. Also, people are included in the program, not in the payment model because in terms of different Medicaid. We work closely with the primary care subspecialists. We are not primary care for the children. We work closely with our own subspecialists and community resources. And you see our aspiration and our goal. We really work on this burden to capacity ratio, as all of you do. These families have tremendous burden, and we're either trying to increase their capacity or lower their burden. And it's also our equity approach. Different people have a different ratio, and it's up to us to make sure that we deliver the services so that everyone's getting the best outcome they can. Next slide, please. Entry criteria. I know this is something that people are very interested in. We have two components. It's a complexity component and a fragility component. The complexity component is you have to have 3 or more organ systems that lead to a chronic medical condition. And then 3 or more medical subspecialists, surgical or medical, that go along with those conditions. The fragility and mental health cannot be one of the core systems. It can be a comorbidity if you're enrolled, but it's not one. We don't classify it as a primary. And then a fragility component. You have 1 or more admissions totaling 5 or more days, or 10 or more subspecialty appointments within the previous year. Now, for our NICU population, this isn't possible. We have to have a projection of fragility because they've been in the NICU and that past year they've been hospitalized. And for we get a fair number of families coming from refugees, and we just can't get medical records. So we sort of project these complexity and fragility components. We also take social complexity into consideration, but it's not a primary element that we look at. Next slide, please. The care model, we have a care team that is one provider. It's either an MD faculty person or one of our APNs. There's a nurse care coordinator who's the focal contact person. That's the main person for the families. And then during the grant, we created this new position of a care coordination assistant. And that person works in a dyad with the RN, to increase the RN's panel size. And that worked very well. They went from being able to have panel sizes of about 45 children, and now between the dyad with the care coordinator, they have panel sizes of 90. So they doubled their capacity by adding the care coordinator. We have one social worker who helps way more than, I don't know how she does it, and it's one of our desires to get more, and glad to talk about that. We have a 24/7 call system. They can get a hold of an APN or MD faculty person. The families can 24/7. We round on all the children that are in our program as consultants, inpatient every day. And then we see them for their enrollment visits where we set their care coordination plan, and we revisit that every 6 months. It typically happens much more frequently than 6 months, but that's our larger limit. It's also part of our deliverable to the state. They're in the hospital or we're calling or contacting them. It gets updated usually much more frequently than that. Next slide, please. I won't go into this, but I'll leave it for people to see. These are the different roles and responsibilities that people can look at. And just to give you a description of what our responsibilities are in these next roles. And happy to answer questions about this with Tara and Sarah as well. Next slide, please.
I'm just going to acknowledge, and there are a few questions that have come in, but I think once we go through your slides, unless you would prefer to answer.
I can pause if that is helpful. We can pause here and answer some of those. I just want to be cognizant of your time as well. So, but I'd be happy.
That's great. There's a couple that are on this specific slide, so maybe we can go through these ones. So Teresa from Michigan is asking a little bit more about the care coordination assistance role. She's wondering if it's similar to a community health worker role.
Yes and no. Our program is primarily out of this tertiary care center. And most of their work is around coordinating their appointments and liaisoning with the community. So a lot of work is done with schools. They do a lot with helping get paperwork, forms done, working with our waiver program here in Wisconsin to get financial assistance to the families, helping them decipher some of the Medicaid forms. And then they do work with community agencies, but we're not out in the community as a hands-on navigator. I don't know if that answers it correctly. And Tara could pop in too. She may have more on that than I just distributed.
Thank you. And I think Tara is answering in the chat right now too. So some of the questions are getting answered live in the chat as well. One other question that came in is, how do you identify chronic conditions? Can you say a little more about that?
Yeah, we do a chart review, and we see what the child's history has been in, let's say, their pulmonary condition, and are they seeing a pulmonologist, and what is that diagnosis, and does it fit what we would call a chronic condition they're going to continue with it. It's not going to be something that is easily resolved. So that's primarily how we do it. It's pretty broad in that surgical conditions are included. That again, somebody with scoliosis who has ongoing needs would also be that would fit.
Excellent, thank you. I think the rest of the questions have been answered in the chat from your team members. Thank you, everyone. So I think we can keep going. Do you want me to go to the next slide, or are you done with this one?
Yep, I think so. Thank you.
Okay.
Yep, I won't spend most of this is the work you all do. It's simply we're there to provide the work for a family as they interact with multiple subspecialists in our hospital. The co-management component, the things out in the community, and then our own continued research to really identify the quality measures that will make this better. Next, please. This slide sort of depicts on what happened with the grant. So the grant started around 2013, 2014. And we were at maybe a little less than 200 families that we were serving. Then you can see the large expansion that happened really because of the grant. And the change in faculty and staff positions were pretty large increases. In other words, and to get us to these panel sizes, so per MD faculty person, they have 1 to 70 families they serve. The APNs, it's 1 to 80. The RN, CCA diet, it's 1 to 90. These panel sizes were kind of put together in a way that we made the best guess we could. And Tara and I pretty much call it working on the back of an envelope. Some of it was, we knew we were overdoing it when people came into our office crying that, it's like, that's enough. We gotta maybe not give them any more. But I think it turned out to be pretty good. We actually projected about 15 to 30 more children than what's represented here. But it was interesting with all the onboarding. We had a little bit, we built in an attrition factor that we have very low turnover in our program, but occasionally someone does leave or goes on maternity leave. And then we have to shift all these patients around to everyone else to make up for that. And we didn't want to overtax our group. So we said, well, let's make our upper limits less than what they think they could be, so that when someone has to leave, we can shift things around and not just destroy our teams. And I think that's proven to be very helpful for us. It's also setting these panel size also let us know the size of the population of children that we were going to serve with Medicaid. And so the second component of our payment model starts to materialize. They know our costs. They know how many children we can care for per that cost. And that comes into play in establishing how much are they going to pay us. I also like to point out that John Gordon retired around 2015. And you notice right at the slope of that line that's going up, John shifted out. So he was a pretty smart guy. Next slide, please. So how to pay for this work. We've talked about this a little bit already. They know how much we cost, and we included everything in that, not just a physician fee or an APN fee or a facility fee. They knew the cost of our RNs, our CCAs, our faculty, our APNs. We included our administrative assistants and our research coordinator. That the grant and that what we were paying for, it was a program wide, and our social worker. So that was important, that they knew our costs. They knew how much we were billing in the current RVU billing face-to-face approach, and they knew what we were billing, and they weren't reimbursing. There was codes, but they knew they weren't reimbursing that. So they had a pretty good picture of our finances. As we stated before, once they knew our panel sizes that we could care for efficiently and with high quality, they knew how much the staff per cost of patient was. And now what we really needed was a measurement to justify our work, that this is, yes, we're really doing this, and what was billable and what was not being reimbursed. Next slide, please. So the dreaded time study. Fortunately, John Gordon, before I arrived, had done time studies quite a bit with the crew before I started, and so they were used to it. And Sarah had even done some quality analysis to see what was being reported was of high quality. So we said, well, we need to justify this payment, and we looked at 3 areas of environment of care. The initial enrollment period, where we enroll children, and then what goes on as long as they're in the program, and also included looking at what we did on the inpatient side. We also looked if it was being all the unfunded things that weren't being reimbursed. So all of our huddle times, when we huddle every morning, go over all the patients, there's no way to code for that. All the time that's being done consulting and talking to other consultants, there's really not a code for that. All the work the CCAs were doing with schools, there's no code for that. So we wanted to look at all of our time and also see which portion of this time was reimbursed or not being reimbursed. Some of the tools, this time-driven activity-based costing tool was, did we do that? Kind of, not completely. I'll show you the tool we used in a moment. And I know you've all studied the care coordination measurement tool. And I think that tool definitely influenced us. And I'm going to say Tara and Sarah, because they're the ones who put this tool together. But there are different ways of demonstrating your work. And again, it gets to that numerator portion of the value equation. This is the work you're doing to deliver greater value. And so getting reimbursed for that is much different than always concentrating on lowering the cost of what you do that might impact what you do in the numerator. So we wanted to be good stewards of our utilization, but we really concentrated on getting paid for the work we were doing. Next slide. And this slide is the tool that we used. Again, this is Tara Bartel, Sarah Johannesmeyer made this tool. And the different components of it, you can see that every staff member had to count for every minute of every day. They had to show what they were doing in relationship to which patients. And looking at the enrollment phase of it, the ongoing care, the inpatient work, if we made home visits, if we were involved in transition of care, and non-patient specific, but program related activity. Those were our huddles. Those were the meetings that we were having that related to multiple patients. And check-ins with family. But we really tried to account for every moment of our staff's time. And we did this across all of those different responsibilities. So the CCAs, the nurse, the physician, the APN, our administrative assistants, our research coordinator, everyone was filling this out. Next slide, please. And the results of it were interesting. This is composite. This is not the individual staff members, which we have, but this is for the team. And we can see within that first couple of months, that's where we spend our most time. That enrollment component is the most time consuming as we bring on new patients, which makes sense. And then we hit a sort of a plateau, and we stay pretty consistent on the amount of time we were spending on any one child on average. And this was really valuable in how they set the payment model. Next slide, please. So Milliman was the actuarial firm that was doing this as part of the grant. And they simply took all this data and said, well, we know the size of your program. We know that projects to a certain number of children you can care for based on your panel sizes. We know how much it costs. And we've looked at your time study to know where is it that we can, that you have credible work that is billable and non-billable, that we can make your program as close to whole as possible. We of course adjusted for the Medicaid population only, because this is a Medicaid program. We have about 90% of our children we care for are Medicaid, so it encompasses a vast majority of our program. And they came up with what was an enrollment fee, so that portion that is the most time consuming, and an ongoing fee. It's essentially a PM, but Medicaid would prefer that we don't call it that, because it does, we do have to have meaningful interaction, and that's again where our relationship, the definition of that is quite broad, but it works quite well. So these are the two fees that were paid. The next slide. And this is what our fees are. This is ongoing targeted case management for the children who are enrolled. It's about $1,100 on enrollment. And then on a monthly basis, meeting their deliverables, it's about $400 per family. It turned out close to what John said. John said, it's simple, just pay us for the cost of the program. And it kind of worked out that way. And it's been a very nice partnership. So this initially started out as a state plan amendment. Next slide, please. But it moved right into being a part of Medicaid, which we're grateful for. The deliverables are pretty much process measures right now. We are working more on patient-centered outcomes to incorporate into this and to work with Medicaid on holding us accountable to them. We think that's really important. We have to do the comprehensive assessment and care coordination plan and renew that at least every 6 months. Identify goals and a course of action and a time frame for those goals to occur. Ongoing monitoring of all these things listed here. We also do a annual satisfaction survey with the families that we present to Medicaid and our primary care partners that we also serve and our subspecialists. Our ongoing quality improvement activities that are really, again, very patient-centered outcome in nature. So it's, we set up a registry to do this more in an automated fashion, and it's been able to help with our audits. We get it audited about every 6 months for Medicaid, and it's gone pretty well. Next slide, please. This is just a sample of the last survey we did. We haven't done any during the pandemic. We are sending them out again currently to get more information on our program. But in general, our families like us. They like the program. Part of our research is actually trying to focus on what is it about us that you say things like, you can't live without us. Wonderful, we love that, but we really want to know why. What is it, what component of aspect that we're helping you with mostly so we can be more efficient. So a lot of our research is directed at that. But the families like us, the PCPs we work with, we have a great relationship with, and then Medicaid loves to see this. Our payer loves to see that, oh, this is working. Next slide, please. Again, we keep doing, we will continue to do and watch our own finances with their cost of care and our MOU with data with the claims, payment claims. We'll continue to look at the finances to make sure it's pre-post. We're looking for control groups. We're trying to talk to various economists to come up with a better comparative approach. But right now, we want to make sure at least we're doing this. And I forgot to mention, I think we definitely take the NICU children out of this. That would be too easy if we left them in. Next slide, please. So it's a novel payment program. It's ingrained in Medicaid. It's team-based payments. And then when I say that, at most academic centers, we have a hospital component. That's our nurses and CCAs. And we have a medical school component, our APNs and our faculty and our administrative assistants, research assistant. We're paid as a team. And then these two partners have to split that money. It actually forced them to get along pretty well, but it's not as easy as it sounds. And there was a lot of discussion over how that would happen, but it's worked out well for everybody. But it is an important aspect, and I think a positive that it influenced. It covers all the non-face-to-face time while preserving the traditional face-to-face billing system. It's a carve-out in the sense, many of our Medicaid programs here in Wisconsin already have care coordinations. They're the HMOs for the children, but the state realized that you're not going to be double dipping, doing double service. We're going to carve you out for these children specifically, and that was a big plus. It covers about 85% of our program costs. We have a little bit of an issue on the medical school side in that we don't have a lot of RVUs, because we get paid in cash revenue. And so this is not insignificant with payers and providers. We're ingrained. There's a lot of inertia to go away from the RVU payment model because all the systems are set up to do that. This system bucks that. And part of our success was during this 5 years, we had our finance people once a month meeting with us and saying, okay, you need to keep us involved because we need to work on our end, all the things we need to change in our computer systems and to send out this bill. And then Medicaid started talking to them way far away from us on what they were going to need to accept the bill and send payment back. And that work apparently is not inconsequential. And in talking to others around the country who have done very similar great programs, they built the program first and didn't talk to the payer. And the payer would say, I like it, seems like it would work. You know how much work I'd have to do to change how I bill? Or on the payer side, you know how much I would have to change to give you the money to make that happen? There's a lot of inertia in our system, and it's another reason why I think working with the payer up front is really important. Next slide. I think there's just a couple more slides. Key concepts, I think we've gone over most of them. Work with the payer up front. If you build it, they really might not come, yet you need to get them in early and hopefully let them know what you're doing. The inertia we talked about. Use your friends, government liaisons at your institutions. The stories really make a big difference. Relationship with your own hospital, so you get that support from the executives and leadership. The demonstrated work tools. Be wary of the shared savings. We're too small unless you're going to have hundreds of thousands of children in your population. I would say try to stay away from it. Try to get paid for what you do and then deliver the value. And most of the time, if you deliver high value, costs come down. And the payers that work with you will realize that. And yeah, you need a little luck. And I think we had more than a little. Next slide. And just briefly, this I think is one of our last slides. This just shows just on the faculty side and the APN side and our research coordinator, and Michelle Huntley, who's on the call today, our administrative lead, who is wonderful, helped put this together with Sarah. It's just a slide that shows the green part. That's our revenue attributed to the payment model. The upper blue area is the portion that's attributed to volume, face-to-face, RVU generated revenue. And the yellow line is our cost. The other line there is the increase in census. And you can really see how dependent we've become on this payment model. It's about 2/3 of our revenue, but it also makes us sustainable. If not, we can actually have a little extra revenue. And the other interesting thing about it is you can tell where the pandemic hit, and revenue kind of fell off for everyone, but we did fine because of the value component of still working with these families and all the things we put in place that worked even during a pandemic. So it does work. It's very helpful. And next slide. I think that's it. Yeah, this is the crew. They're great. I'm a lucky person to work with all of them. And there's a little bit of a gender bias in the group, but that's okay. It's really a great crew, and I'm very fortunate to have the privilege of being a part of it. So I hope I didn't take too long. I hope I answered. I'm happy to answer questions. The other part is we have a family advisory group we work pretty closely with, and they keep us in line about whether we're serving them, and we're starting to get them more and more involved in the capability, comfort, calm approach on what that means to them. And our Family Voices group here in Wisconsin is also absolutely wonderful. A big part of our COIN project that Sarah and Tara are working with them. And that kind of relationship with the state helps when you have those types of advocates really helping us. So we appreciate Barbara Katz and her and the Family Voices crew, just a great crew here in Wisconsin. And I think that's my last slide. I think so.
Thank you so much, Tim. That was awesome to hear about your program and all the work that you guys have put in and continue to do. There are a few more questions in the chat before I think we jump into our full discussion. If you don't mind, we can go through those. Sure. From Mark Mailer, what was the trend for total enrollee expenses?
Not sure I completely understand the question.
Mark, do you want to unmute? You're welcome to discuss if you'd like.
Afternoon. Hi. I really appreciate this presentation. Thank you so much. There's so much information here. And I had two questions. One, you mentioned program costs in that last slide, but I wasn't sure what that included. I was looking for a slide for the actual medical expenses for the enrollees of the program and how those changed over time. Did they go up or down? And how was that? And including the program costs, the extra payments, what happened to the total expenditures for the Medicaid program? And then my second question was around were the social determinants of health addressed, and if so, by whom? But thank you.
Yeah, two great questions, Mark. I think the slide that had the pre-post numbers on it is probably the best representation of what happens over time with the total cost of care of the children as they're enrolled. That slide is generated by looking at least 45 days. That was our minimum that we used of the children in those various costs of care that are listed on that slide. And same amount after, or if not longer, for their in a comparison. So their total cost of care went down. Most of it is attributed to inpatient utilization. and length of stay. That's where we think we make the biggest difference. And we have ideas on why that happens in terms of being a trusted advocate and giving the families a little more confidence and the teams a little more confidence in discharging families a bit earlier than they normally would. So the other slide is when I say program cost, that is really the cost of the staff and our rent and our housing and our pencils, and it's our total cost in that last slide versus the revenue generated to our partners. And we use that to really ask ourselves the question, are we financially sustainable? And where are our finances coming from? And to demonstrate how important this payment model is to our sustainability and to the goal that was set up in the grant. That was one of the goals, make a sustainable payment model. And I think that slide demonstrates that they were able to do that with us, which we're very grateful for. I hope that answers the question. Oh, determinants of health. Social determinants of health is, do we do things with that? We do, in that we really try to impact, things like medical literacy. We concentrate on this. We're able to help with the near medical things. We try to help with housing. We try to help with, we definitely help with transportation, things to get people to and from the hospital. We have a big push on medical literacy that really, we don't just say, here's your med and you're done, or how to use your durable medical equipment. So we spend a lot of time on things that help the families actually do the things we're asking them to do. But in the nature of helping them with housing specifically, or helping them in the environment they live, we're not able to do that as much. One of our other ideas is, we're trying to set up a pilot with the hospital, is to hire more social workers, because we think that that's the group that's best educated to do those things. And it's a frustration for our nurses and CCAs and faculty. We reach the limits of our knowledge and where we're best in our expertise. We actually think if we add a social worker to the dyad, make it a triad, that everyone's job satisfaction would go up. Most importantly, we'd have a person with the expertise needed to impact these things for these families. And then that gets to this burden to capacity ratio. So, and we think that the dyads could go from 90 children, maybe they go to 130 children, but deliver a higher quality of care as well. So it's an area we're very aware of, and we'd like to do more in, but something we still have to do.
This is great. Tim, thank you very much. And I think we're going to sort of pivot to the discussion expanders. We had this conversation as we were planning this, that these are expanders because each of the teams we asked to come has moved along either on payment, identification of kids, or figuring out the workflow. So we want to kind of interweave some of the themes that we're talking about that Tim brought up with other examples of the same thing or something similar, so that I think it's also, because you guys have all done incredible work, but there's nuance to the way you're dealing with your payers, or nuance to how you're doing time studies. So we thought we'd do that. I'm going to just mention who's on for the expanders. Katie McGinley Kaplan is on the Philadelphia team and is the Director of Grants and Innovations for Community Behavioral Health. Renee Turchi is the Medical Director, the Center for Children with Special Health Care Needs at St. Christopher's, and on our leadership team here. Natasha McClanahan, is one of the social workers in Indiana. And Rahel Berhani is the medical director of the complex care clinic at Dell School. And I want to just also acknowledge, because I think what we'll do is we'll try to keep the chat lively and we'll monitor that. But I also wanted to acknowledge that we wanted to get a payer on here and we didn't quite get them oriented, but we do have on the line Mark Maller and Eric Levy, who are the medical director of quality and the chief medical officer for health services for children with special health care needs in DC, which is I've come to learn is a small managed care organization that is actually part of National Children's National and in the DC area. So I think what we're going to do here, if this is okay, is turn this over. We wanted to talk about these topics, and I wanted to just go through 3 areas with this group in the next half hour or so: payer relationships, how you measured your time study, and patient selection. And so if I could, I'm just going to ask Philadelphia and then Indiana and then Texas to talk about what's their payment model for covering the cost of care coordination, and looking, in comparison to what Tim talked about. And then a really specific, maybe social thing, but I wanted to talk about what was the turning point in socializing the need for payment with the payer, and how did families contribute to that, and if they did any value calculations. So Katie, if I can turn this to you first, if you don't mind me doing that, and put you on for a couple minutes to talk about this, and then we'll go to Natasha and Rahel.
Sure. And just to make sure, so you want me to focus more on the payment first, right?
Yeah, we're going to try to do payment,
Okay.
then we're going to try to do
Okay.
time, and then we're going to try to do how you identified your patients.
Sure. So CBH is actually the behavioral health managed care company for Philadelphia County. So we're a carve-out state. So for folks living in Philly on Medicaid, we are it for behavioral health managed care for the whole county. And we kind of lucked out. We had initially gone for the CMS grant and didn't get it, which that part wasn't lucky, but the amount of work that we put into it fed into an opportunity that the state provided. So it's interesting because I think there's payer discussions that you have at the local level with your MCO, and then there's the state discussions, and they're not always aligned. And so in Pennsylvania, the leadership at the state level became more and more interested in both integrated care and addressing social determinants, and came out with a new requirement. So we're actually program funded, which is, I think, a little bit unusual. And so we submitted a proposal for this new requirement that they call community-based care management. And that's how we're covering our integrated care for kids project in partnership with Dr. Turchi's team at St. Christopher's. Right now, I mean, the state is allowing, they actually added a requirement that we must partner with community-based organizations to address social determinants of health. So again, this is where we feel kind of lucky that we're getting a blessing and the money to do all the things that we think we should be doing, like paying for, the opportunity to do some prevention work, the opportunity to do more enhanced screenings beyond what EPSDT requires, the opportunity to do care navigation. And then we're actually, Dr. Turchi identified 2 community partners. They have a medical legal partnership that's already working with St. Christopher's, and we're expanding their scope as part of this project. And also an organization known as HUNE, which is a Latino organization that works with children and families around educational advocacy. So this idea of, being able to do whole health. So I feel like we're very close. It was like the state was interested in a Medicaid waiver, but we all know Medicaid waivers are a nightmare to go for. And so we're kind of like right there pushing the envelope. But when we had mapped out our grant application to CMS, of course, the one pillar of the integrated care for kids model is the alternative payment model. And so Dr. Turchi and I and the teams often talk about, if the state were to pull the funding, would we be able to pivot to a case rate? What would that look like? And so that's, I think, as we are launching it, literally as we speak, I think we need to be tracking, that time tool. Actually, I'm not familiar with that, Tim. And that was, so I wrote down the reference because I want to look at that and look at your slides, because I know you included it. But I think that's what we're going to have to do just to make sure that we have a safety net so that Dr. Turchi, as she's hiring staff at St. Chris, knows that there's a long-term sustainability strategy if the state were to, and I don't think they will. I think they're going to see value in this.
So Katie, can I just ask to clarify, do you get a per member per month payment
Yep.
for the folks you care for?
Yep, we're per member per month.
Okay, and do you bill anything on top of that for like counseling services or any other RVU generator?
No, I don't. I would have to double check, but I don't think so.
Got it. And then I also want to clarify something for everybody. Carve out means different things in different places.
Oh, sorry.
In Pennsylvania, carve out means the mental health and the physical health are separate managed care organizations. For Tim, carve out means that the care coordination payments that he's doing for those kids, and those kids are in fee for service and not part of a managed care organization. And we'll hear something different, I think. I know we'll hear something different from Rahel in a couple minutes too. So I'm going to ask people to do clarifying questions in the chat, if you don't mind. And I think we'll turn over to Natasha now. And I think I just want to also say that, Natasha, if you would, in your comments, would you talk about the money that Indiana got through the COVID stuff?
Sure. So right now our project is in kind of demonstration pilot mode and has been through the COIN efforts. And because we were accepted into the COIN, Indiana Medicaid was very excited and wanted to come on board. So they funded a 2-year demonstration project starting in 2019 that is a per member per month model. And that's kind of how we've operated so far. Here within the last few months, discussions with Indiana Medicaid has moved because of COVID funding that they've received into how can we expand our demonstration project to statewide. So looking at, our care coordinators are housed in primary care practices through in 3 locations throughout the state. And they're looking at, over the next 5 years, how can we expand that to, add 30 additional care coordinators, and it would be a per member per month model is the current discussion.
Great. And I'll ask you the same thing that I asked over to Katie, just to clarify for folks. The per member per month is for the cost of care coordination, and then are there fees for other in the primary care, like if there's an office visit, do they bill for that separately?
So we're kind of looking at that right now, because what we've received currently is kind of a lump sum, and it's just from my understanding, kind of the the care coordinator's salary, and then there's a a leadership for the primary care doc who is sits on our leadership team. There's funds for them for their time through the grant and things like that. Billing wise, we haven't billed anything yet. We haven't turned on, in quotation marks, turned on any billing categories that I'm aware of. And we're working on that right now through the contracts that we're writing with Indiana Medicaid for this expansion. And so in that model, we're looking at, the primary care doctors, how do we compensate for their time to pool their time for our children with medical complexity that they serve, as well as covering the care coordinator salary as well. So we're kind of looking at all of that right now.
Got it. And we meaning you and Medicaid?
Yes. So we have a leadership team, Dr. Ciccarelli, myself, and Lorena. And then we also have, our leadership advisory council, that we all have these discussions about what fits now, what doesn't fit now. And then because Medicaid has been at the table since the very beginning, They're very involved in that, and we have regular kind of semi-weekly meetings. They've kind of been here and there. With COVID recently, it's been monthly meetings at least, and having those discussions about what is ideal and what do we need to function.
Great. I'm going to turn to Rahel if you're there to talk about this topic as well.
Yeah, thank you. I think it was quite interesting to listen to the Wisconsin presentation, and there was a very lively group text among the Texas team as this was going on, and it was quite exciting. And we need to engage Tim to actually talk with us more. There is so many parallels. To focus, Jeff, on what you wanted me to talk about, the payment. The payment situation for us is this a journey that has kind of followed some of the things that were happening nationally when our clinic started in 2012. The institution that we're part of, Ascension Health, had signed on to be a pioneer ACO, and the CAO at the time wanted some pilot projects that could be done to show a different care delivery system that would then the savings will be shown to get into some kind of value-based contract with the Medicaid or other payers. So we started as a randomized control trial as a comprehensive medical home for these children. And I love the term focus on the numerator. We essentially took our task, those of us who were organizing the program, that we just need to do the things that are going to help families, whether they're paid for or not, whether they're billable or not. We have to eliminate any waste and processes that don't add any value. And we're singularly focused and have continued to be that way in the ways we've approached the work. The entire team is oriented that way. And a year into our start, the 1115 waiver became available in Texas, and we put our program for funding through the 1115 waiver. The 1115 waiver, however, in Texas, at least in our community, was given to the hospital. So initially, our first year was funded by the hospital, but subsequent years have also been funded by the hospital. They just we're getting additional money for this program from the 1115 waiver, which is federal funds that were acquired through the state and some regional entities. That, however, has stopped, and the hospital has continued to subsidize our operations. But in the meantime, as this was going on, actually, there's a whole history of what's happening in statewide and nationally. Texas decided to go put Medicaid all into managed care. And they had a special population called STAR Kids, which includes children with medical complexity, but also has less complex children. Maybe 15% of STAR Kids are CMC, but the rest of them aren't. So this special program was given to 10 different MCOs, at least 2 in every region. So we started talking and meeting regularly with the 2 MCOs that were supposed to be serving our region, even before they got into a contract with the state. And they won. So we had an arrangement with one. We were not successful with the other to take delegation of their service coordination function. It is better done through the medical home. And so instead of hiring nurses at the ratios that they were going to hire, they were going to give us the money on a per member per month basis. And so that arrangement with Blue Cross Blue Shield has been, initially there was no delegation. They just gave us an additional small payment for additional care coordination, but then about 2 years ago, we took on the delegation. It's a tough fit because there was a whole lot of what is considered service coordination, which is kind of doing work that is required for the state contract obligation, which we felt were some of the processes were redundant, some of the processes were not adding value. So we still are continuing and sort of trying to refine this delegation and this partnership. There's a lot of operational challenges because not all of our patients belong to that MCO. So, but we also don't want to operationalize a special care delivery system just for that population. So the money gets diluted there. It does not cover much of what we work because there is quite a lot of children who are not in that MCO. The last thing I'd say is there is a new arrangement now that we are in the final stages of negotiating to support a pilot project funded by a foundation that is called Episcopal Health Foundation that is sponsoring projects for care delivery transformation. And in this one, we are talking about care integration. We are saying, pay us for our work, pay the PCP for the time it would take to do a whole family visit, twice a year, a whole child visit, to put care plans together, to bring specialists into the same session, to have meaningful discussions with the family about their isolation, their social support system, and the needs that are available. To this day, the provider time was never paid for. All the huddles we do, all the care conferences we do, all of this long 2-hour-long visits that we do for care plan development was never paid for. So we are now negotiating to say that just pay us for the cost. We're not addressing the denominator because we believe that if the numerator is done very well and if waste is eliminated, maybe the denominator will take care of itself. So that's kind of where our program is.
Thanks a lot. I just want to say I'm struck by the fact that, and this is through this entire Care Coordination Academy, that this is the group of people who are doing the right thing for the right reasons. And what I really find, and it's really about, and I think we're talking about here is how you all are socializing this and getting the payers to understand and agree with that. I want to ask another question in this round, and I won't make everybody go in order, but I want to ask if and how families are involved in this part of it. And I think that that's kind of tricky because families have a lot to do and maybe more involved in quality measures, et cetera. But I do think that sometimes families can help this and with the payer community. So I'll just ask anybody who's on the panel, or Tim, if you want to talk about that just a minute.
I'll go about our, just to continue my sharing about how we have had family advisory councils all along. We have a family liaison that's on staff. But in this, and one of the things that we had focused on is that, when we say participatory care, when we say shared decision-making, we need to put the processes that would enable that. So we have invested through grant money technology that brings families to the same level. They would put in their own word who the child is. They would upload pictures. They would have access to the care plan through their mobile phone. They will know where their DME is. So there's this level of parity in terms of the hierarchy of care. And in this project, the project that we are now piloting, the outcome measures were actually developed by the family work group in collaboration with the Value Institute to measure the alignment of families with their care team, how included they feel and how much calm, the calm element of how much calm has actually been provided through this process that we are piloting. And this is largely actually as the culture that has really been reinforced through the coin. The emphasis of the coin on family engagement had enabled us to recruit a whole lot more families and to continue to support them through their work over the years, to the point where, you know, our coin meetings and our monthly stakeholder meetings are chaired actually by a family person. So this is a very high priority for us. And we have involved families a lot more in our operational discussions. And there has been a whole lot of sharing of what it is to operationalize a certain process. And there's a lot of insights exchanged from both sides. And families are now quite aware about cost and the pressures that we have from the hospital side, from the payer side, the processes that we do to justify our work. So it's been a very incredibly novel partnership. We have always had it, but not to this level.
I think what I heard from Tim and hearing from you, Rahel, also, which is that the families help make the measures that then go back to the payers. And I think that's important. I want to ask Katie and Natasha if they want to add anything around this before we move on to talk about some more stuff.
Natasha, do you want to go or?
I was just going to second that. Yes, that was what we did in Indiana as well. Is, you know, we had focus groups in our family satisfaction survey, really informed the kind of process measures that we're utilizing and taking to Medicaid to say, you know, this is what we want as part of our payment model and measurement on. So I just wanted a second, I guess third.
I mean, I think in Philly, we're pretty lucky. Peers are very much embedded, not only at our provider agencies, but in our Department of Behavioral Health and at CBH. You know, so we have a number of people with lived experience at work in managed care. And we also have had a system of care, SAMHSA, system of care grant for a long time. We have a family member committee that's a part of that. So the family member lead for this project came out of the system of care work. So and I think the Care Coordination Academy has been helpful in giving us the structure to utilize the families more explicitly around particular things like which social determinant screening tool should we use? What's the process? I mean, one of the really early meetings on people talked about how it's annoying to be screened when you feel like you're just being screened for the purpose of collecting data, and how not to do that. And so we had some pretty robust conversations with family members about that. The other thing is our model includes peers. So again, if you know, the role of lived experience should be a cornerstone of any of this work, whether it's integrated care for kids or children with medical complexities or whatever it is. And so in our model, the staff that Dr. Turchi's team is hiring are going to be individuals with lived experience. And since it's, you know, the idea is blending both physical and behavioral health, you know, the community health worker role is more the lived experience on the physical health side. On our side of the fence in behavioral health, it's certified peer specialists, which are Medicaid reimbursable. Ideally, we want caregivers and also family peer specialists, which is a new, it's not new, it's actually frustrating because Pennsylvania should have it as a standalone Medicaid reimbursable service and have just had a lot of changes in leadership and it's been slow. But what we did is we made these navigator positions on the St. Chris side be that the requirement is that you have lived experience. So you have to either be a family member of a child with healthcare needs, you have to be an individual with lived experience with mental illness yourself, or you have to be a community health worker. And so the people that will do the initial engagement with family members will be people with lived experience from the communities that they're serving. The other place where we've gotten input has been around any of the informational materials we've developed. So we have 2 different documents, and the family member committee, they gave us, it was 2 hours. We spent 2 hours nitpicking apart our infographic, which was great because we want it to be accessible to family members, and they did not hold back in any of the feedback to us. So that was really helpful. And so we made real-time edits to our informational materials based on their input. And then I think the last thing is other people mentioned too is the evaluation piece, right? Getting their input. So we do have money set aside to do primary data collection. So our measurement strategy is robust, and family members will absolutely inform the measure that we select or measures, as well as when we test it. So that's some of the different ways that we've had family member involvement.
Thanks. We have a great set of questions in the chat or discussion coming from Megan, Montana, and then a response from Sarah in Wisconsin too about the challenges and leadership opportunities and representation and diverse and of the diversity of families in the work is challenging. Who is not participating in the work group and surveys? What are we missing in opportunities to co-design? I don't know what PSE improvement are, but I'm just curious. I think that, and Sarah just said that they struggle with that. And I just wonder if anybody has wants to say anything about increasing. I appreciate what you said, Katie, about diversity in the workforce, but I just wonder if if anyone has done anything to reach out to a more diverse set of family members.
I mean, Philly might be a little bit easier because Philly's a large urban environment that's just diverse. And unfortunately, we're also very poor. So we have a huge Medicaid population. So when I mentioned the system of care, the families that are involved with that are families that have lived experience with the child welfare system. A number of them also have their own behavioral health conditions or children with behavioral health issues. So it's over 100 family members that are part of that group. So, I mean, for me, it was already created. There was already a forum, and it was easy to go there and connect with those individuals to get input on this project. And they were excited to hear that the project was happening because some of them get care at St. Chris, but they were just excited to have the opportunity to weigh in. And I think because they've had child welfare involvement, or because they've had their own mental health issues, or this array of experiences, we were lucky. So I don't know whether, I know system of cares exist in lots of states, that SAMHSA has been, doing this work for a long time. I'm just wondering if, thinking about different partners, like, in those different arenas around child welfare or other lived experience areas might be one strategy for just getting diversity of experiences. I don't know.
Yeah. Katie, it sounds like your family input has been an ongoing thing that's built for a long time. And I think that's probably
we were lucky.
Important part of that.
Mm-hmm.
Natasha, can you want to add here?
Yeah, I think for us, we've seen a continual kind of uptick in the participation in our family surveys. And I think when we saw that, it was a transition of really engaging our care coordinators and the primary care practices in kind of asking their families that they see, every day, all day long, to participate in this survey and kind of really explain to the practices and the care coordinators themselves, like why this is so important for us to get as much feedback from as many different types of people as we could. So offering it to every single, person that is on their panel and how they talk to their families about what this survey was, I think for us, a big reason why we got as many as we've gotten throughout COVID in particular, because that's primarily when our cycles have been going on. So having that direct outreach was hard at the beginning, but once, we got the buy-in from the practices and the care coordinators themselves of why this data is so important and why we needed to give this data to Medicaid, we got that buy-in from them, which then, provided the buy-in from the families to participate in one more survey type of thing.
I think both you and Indiana and Philly it's a tribute to how people will respond when they think that their voice is going to be heard. So I think that's really the message. And I think heard by the providers, but also here rolling that up to the payer level, which is, I just want to say, from sitting in a Medicaid seat for a long time, that stops people from looking at their phones while you present the data to them, because they want to, it's data, it's the real person data, whether it's what Tim did by socializing it and having people show up for Medicaid and do rounds, or this. So I want to move on if I can. We just have a few more minutes. This is a great conversation. We have about 5 minutes to wrap up. I had two other topics I want to ask our discussion expanders if they wanted to talk about it all. One is, and they're both a little specific and geeky, but I think they're important. One is about patient selection. Tim presented his patient selection, and I thought that was really important, and also to get buy-in from the payer around that. And then also around time studies and how the nuts and bolts, if you guys did any of that. And I'll just go back and open this up to the folks from Philly and from Indiana and Texas, if you want to talk about how you sort of prove the time. I know some of you have alluded to it already.
I can speak to patient selection probably more easily because I feel
Okay.
like we're, so for that one, I mean, we were trying to take a population health approach where the goal would be to not only identify kids that are known to us, but maybe falling through the cracks or need more support, but also to identify the children and families that aren't on anyone's radar, but should be. So right now, the strategy is that so we're basically taking our clinical care managers from, from CBH and pushing them in. They're going to be physically on site at St. Chris, working as part of the interdisciplinary team, which includes the navigators as well as all the other personnel that make up a child well visit. And so our staff are going to participate in their daily huddles, but even before they do that, they're going to have a list of the children that are coming in for well visits so that we can look in our data systems to say, oh, this kiddo has been hospitalized and we haven't seen any follow-up behavioral health care services. This is somebody we really want to target from a behavioral health perspective. So we kind of created these sort of three buckets, is that where we would imagine on the St. Chris physical health side, they might have kids that they know they've missed well visits or there's been some issues that they want to target. We would have kids on the behavioral health side that we would want to target, but our hope is actually still to do a broader capture of the screening tool that we're using to identify children and their parents not known to us, to also identify we are doing an intergenerational approach. So we are, and this is something that actually the doctor that had St. Chris's Center for the Urban Child said, that they often do make referrals for moms for depression or behavioral health issues, but then they have no idea if they ever connect to the service. And that's where Inc. should really step in, right? Like we should be physically there to engage them and then also follow up with them to make sure they're connected. So that's sort of our strategy. We have not implemented yet. So we're talking about, Dr. Turchi and our teams are talking about, we're going to be learning as we going, and I think tweaking, and we have more risk tiering set up for how we're going to do the care management once we identify a kiddo. So if it's a kid with multi-system involvement, would be care managed differently than a kid that maybe just has some more lower level needs versus a child that hopefully is doing well in terms of the type of care navigation support they might get.
Great. Thank you. Anyone else want to weigh in on the patient selection or your time stuff? Just for a moment.
This is Rahel from Texas. We haven't done time studies. We are now talking about doing some mini time studies to show, even to show waste, even in some of this required processes that we don't think add value. Population selection, we have sort of used a definition that kind of gets us CMCs. It's a combination of functional impairment, technology use, and certain diagnostic criteria. We've been looking to standardize this even amongst the other complex care clinics in the state. That way we have some benchmarking capabilities, and maybe looking to the ACE Kids Act to sort of help in that standardization, but we end up with maybe a more proportion of neuropalliative children and moderate to severe neurological impairment with using our criteria, because that is often associated with a lot of functional impairment and technology use. So they check all the boxes. But we have also a lot of children with significant fragility, with multi-system involvement, a lot of cardiac and pulmonary trach vent children. So that's sort of, we have our own enrollment criteria. Includes also utilization, hospitalizations, number of specialists. So we have sort of created our own grid against which we check for enrollment. We don't look at insurance. We don't look at, you know, whether they're insured, uninsured, documented, undocumented, whether they're on managed care or Medicaid. We don't look at that.
Yeah. Thanks. I think sometime it would be interesting to, you know, compare enrollment criteria, but I think this has been, hopefully for everybody on, a very helpful session to look at the relationship to the payer, the way the families have been involved, how the systems are set up. I'm going to turn this back over to Heather for a quick break, and then we want to switch you guys over to your teams and hopefully have some time, as much time as you can have in your teams, to talk about how to apply what's been discussed here. And then hopefully some of you will be able to get back and report out to us at the close. So Heather, can I turn this back to you?
Yeah, thank you, Jeff. And thank you everyone for a great discussion. We really appreciate all our discussion expanders that came on today. What we can do now is go ahead and take a break, and we'll have you come back at 1:45 to get you over to your team breakout groups. So feel free to go ahead and take care of any of your needs. I'm going to pause the recording for just a little bit so we don't bore you all with posting this up. All right, we're back. Yep, and the numbers are climbing up right now. I think we left off at about 80 or so.
Yep.
Let's see.
Okay, let's go ahead and get going. Is that okay?
Yep, go for it.
Hi, everybody, and welcome back. I hope you had productive discussions. We want to take just not enough time, but 3 to 5 minutes to ask Eric Levy and maybe Mark Mahler as well, who are, as I introduced before, who are the CMO and the head of quality at the Health Services for Children with Special Needs in DC, to just give us a perspective of what they heard from the managed care point of view. And I think it's just interesting. You know, I think there's way more than we can get into in just a few minutes, because we want to get to your presentation or your thoughts as well. But I wanted to give them a chance to react about how value-based purchasing is seen on that side of things and where they're thinking about going. So Eric, can I turn it over to you just for a few minutes?
Sure. So I'm Eric Levy. I'm at Health Services for Children with Special Needs. We're a Medicaid managed care organization in DC. We only have 5,000 members. They all are children 0 to 25 with SSI. We estimate somewhere 5% to 10% are children with medical complexity. We typically have like 250, 300 who are getting private duty nursing, usually who are technology dependent. And in DC, which is fairly small geographically, we have 6 major primary care providers: Children's National Hospital System, Georgetown, Howard University, and 3 federally qualified health centers. And we're currently embarking on developing value-based contracting arrangements with all 6, but we only have with Children's National so far, value-based contract where we're proposing a shared savings model where we believe in the medical home and primary care provider driving cost and care, and that if based on a risk-adjusted model of predicted costs, they are able to show decreased costs for those members, they can share in that savings. And the idea is that it's risk-adjusted costs, so that if the complexity of their patient panel goes up over time, that the expected cost would be higher. And so achieving a savings target doesn't get harder each year. And then there's also quality measures that are being used in order to get that shared savings, and they have to hit the quality targets as well. So they're mostly based on HEDIS measures. HEDIS measures are generally quality measures approved by the National Committee on Quality Assurance that are claims-based. So as an example, one is related to weight assessment and activity. So you're supposed to measure BMI, you're supposed to do counseling on weight management and activity, as well as nutrition. That's a hybrid measure, which you have to look for through documentation and claims. And then others might relate to immunizations, asthma, et cetera. Most of them are not related to children with medical complexity at all, but are more for well children. But at least we're starting with that. We hope to eventually add other measures that may reflect more a complex population. And what we haven't added yet are measures that relate to family, but possibly the CAPS measures might be used for that in the future. And I think Dr. Mahler could speak to that probably better than me.
So I can, if we have a couple minutes, speak briefly to these issues as well. So on the, as far as the quality measures, the HEDIS and CAPS measures, of course, are universally measured. They have standard definitions, and so that's why we like to use those. In my experience in other plans, it's helpful to start with a dialogue with the Medicaid agency or the overall payer about the priority public health measures for the population, and to get everybody who's involved in any kind of value-based contracting to focus on a limited set of measures, and ideally with a menu of maybe a half dozen that a practice can get arms around, and that you can get everybody rowing in the same direction. So the challenge would be to find the measures in the medically complex space for everybody to agree on, and then the CAP survey for the patient experience. On the medical expenditure side, Eric has mentioned about the risk adjustment being front and center, and I have some experience in other settings with actually episode-based payments, which used risk adjustment. There were some challenges with the small numbers that are involved in focusing on episodes in a program, an episode such as an episode of illness, such as acute coronary syndrome, or an episode of a procedure, which could be a colonoscopy or percutaneous coronary intervention, something like that. So the episodes, you start with a risk adjustment. Unfortunately, that doesn't totally capture the total risk. So the other thing to look at is a year-over-year change for the population, and then compare the average risk year over year in order to make some adjustments. And then the third piece, and we haven't gotten into this yet with children's, but the third piece is the either a stop loss or a removal of outliers, either through a statistical process. Windsorizing is what I've been familiar with in patient-centered medical home types of programs where we had incentives. We were able to smooth out the maximum expenditure per high cost enrollee, and still incorporate the revenue consideration there. So those are some of the key things for cost. And then I would point out the importance of data sharing if we look at opportunities for being able to improve quality while we are reducing expenditures. And that has to do the data sharing to find out where are our opportunities. And invariably, they're just blocking and tackling types of things like preventing readmissions through coordination of discharge planning between the providers and the payers, for example, between the PCPs and in the hospitals. It's the same thing for emergency department encounters, and medication adherence by being able to provide a list of delayed fills to the practitioners and things like that, just basic blocking and tackling to be able to improve quality while reducing the expenditures. So that's just a very brief overview. Thanks.
Thanks, gentlemen. I hope that it's kind of interesting. I hope that there's, a bridge that can get built between the clinicians, I will say in DC, but everywhere in the country who are doing this work. And in some cases that we heard earlier are really creating measures that matter to families at the same time looking at utilization. And in your case, managed care plan for Medicaid and the Medicaid agency. And I think that socializing, linking all those three together to create value for families, I think, and then also value for the system, I think is the great opportunity we have here to move this going forward. So I really appreciate your comments. I'm looking forward to all the things about the risk adjustment, which is the geeky Medicaid stuff, I think is really important. But I think I'm looking forward to getting hopefully we'll continue to move the measurement and the payment mechanisms forward. I want to pivot to Rich, who is, I think, going to take the baton to sort of hear from teams. So I guess I'd say I'll let you do that, Rich, and we'll go from there.
Thank you. We really appreciate it. And I'm so glad to see that people are paying attention to Heather's request in the chat. I'm going to do a very high level summary and purposefully map to what have been some of the core themes of the Care Coordination Academy. We'll leave some time that if people want to, in addition to putting something in the chat, summary at the team level, ask questions, make a comment. So what did we hear today? We heard that you can get to this so-called three-legged stool differently. Timing is really, really important. In fact, it was a reason that I mentioned my connection with John Gordon when I first met him a decade and a half ago in Wisconsin. And interestingly, a decade ago, the Wisconsin Medicaid folks were already at the table and they were trying to work through some of these issues. And so they were cultivating that relationship. What else did we hear that is important to the Care Coordination Academy? It's not enough to say we're doing really important work. You need to kind of say, well, what is it that you're doing? And so thinking about the articulation of the model, who's doing what, try to get the folks to the top of their, if not licensed, and of what their job capacity would be. Something in the Wisconsin model that I really liked are those care coordination assistants that enable the care coordination done by the nurses to be able to expand. There's no doubt in my mind that care coordination and care integration are team sports. And everybody in this Care Coordination Academy knows that. And then finally, thinking about what are some of the measurements. So Eric and Mark were able to join us, and I'm grateful to them, their busy schedules, that they could make the time. The current tools, the current measures for children with medical complexity are few and far between. And as somebody that actually advises multiple state Medicaid programs and the Centers for Medicare and Medicaid Services and the National Quality Forum on measure selection, I can tell you, you might have the most perfect measure for that child who has a condition like sickle cell disease. And in fact, we do have a very appropriate measure of quality for sickle cell disease, but getting state Medicaid programs to deploy measures for relatively small populations is exceedingly difficult. So I really like the theme we heard this morning about what are some appropriate measures that would cover large swaths of the pediatric CMC and CYSHCN population. functional outcomes, quality of life outcomes, experience measures. There's the family experience of coordinated care. There's the pediatric integrated care survey. There are the CAP surveys. And I think if we're able to track utilization of these populations by functional outcomes, quality of life outcomes, utilization outcomes, then I think that that's directionally where we want to go. So I'm going to open this up now. I think that I've got one question that came from Annie out at Chalk and her team. And Annie, if I didn't get the question correct, please, well, in fact, rather than wasting time, Annie, why don't you just unmute yourself and ask me your PICS implementation question.
Oh yeah, thanks for reminding me. So I had asked earlier, I think we ran out of time, just if for those of you who are doing family surveys, just any successful ideas, any pearls that you have, if anybody's been able to do texting the survey, at least the survey link, or if they're using something other than PICS.
Yeah, so I'll answer a piece of it, Annie, based on what I know, but then all of the Care Coordination Academy members on this meeting today, please feel free to jump in either in the chat box or to unmute yourself. But Annie's wondering about, how can we get families access to either the PICS or other surveys. So the PICS instrument, or most of its deployment, actually is done through electronic link transmission. That can be done through email. It could be done through text. In my experience here at Boston Children's, it's probably done more through email than on mobile devices, but there's no reason why it can't be done by mobile device. And I know that some places are using CAPS, not just the traditional CAPS assessment, but also using that as electronic transmission of links for families to respond to. So are there any other folks that have experience with any kinds of surveys? If so, either unmute or put it in the chat, please.
Thank you, Rich. I should say we are emailing and we're just looking for a more robust response rate because, I think texting is a little more accessible to probably even all of us. So I'm just wondering if anybody's been able to make that happen.
Well, I can add a little bit more. It's a little out of scope, but Annie, for the sake of transparency, so we're in the process of getting security clearance now for our so-called Care Map app. Rhonda, Katie, I want to acknowledge your email request about Care Map. It is a patient-held application. It actually, our team was honored to have won the MCHB Grand Challenge for CYSHCN. Anne-Maria Padlin and the team at MCHB and Dr. Michael Warren, thank you for that. It is a smartphone app. The next generation, Annie will put it on Android, but it actually has patient experience questions embedded in it, in addition to the patient being able to communicate directly with members of the care team through a clinician-based dashboard. It's undergone some testing for proof of concept. And I think it'll probably take another 3 or 4 months to clear IRB and security clearance. We'll be sending out announcements to Care Coordination Academy folks as soon as it's available for testing, but we're excited about it. The first wave of testing will include both adults and children with special healthcare needs.
Rich, there's a bunch of comments in the chat that I think are really states talking about their progress. And we have a few minutes. I don't know if we want to, I'd love to go through a few of these if you want. Is that okay?
Oh, absolutely. In fact, why don't we do this sort of in a tag team? Why don't you go ahead and start, as I was focusing on my response, and then I'll follow
Yeah.
on.
So I'm gonna ask Minnesota, because it's my roots, to jump on just for a minute to talk about next steps and challenges. And if you could keep these short, I'd love to hear from more states.
Yes, so we were inspired and excited, especially from our neighbors across the way in Wisconsin. Go Pack Go, thank you. But kind of our wins, we feel like we have a lot of great experience from our complex care program, and we have strong measurements in place for time study and family perception of care. But where we need to go next is building that really collaborative partnership with our payers. And so low-hanging fruit is connecting with our MA medical director and hopefully getting them excited about what we're doing and potentially willing to partner with us on a pilot program. And then we also want to do a better job of surveying our primary care partners and outside specialists with our system. We liked that Wisconsin did that as well. I think it's an important outcome measure for the work that we're doing.
Thanks. I'm going to go across the Midwest and ask Michigan to go next, because we already heard from Wisconsin, so we get all three.
Okay. Michigan was engaged in a good conversation. Really, what we really need to do at this point is we put in a lot of legwork in order to better understand who the population is, but now we need to firm up those numbers. We need to get more understanding about what the state budget is and how that's going to be able to impact us, as well as the other states' resources and priorities. We need to think about tracking the costs. The question keeps coming up is, how much does this service cost? And so we need to really go back and revisit the care coordination measurement tool and seeing if we can implement that in a way so that we can get the results that we can then analyze in order to be able to determine what the cost of it is, and really what are the costs that are not being currently reimbursed. And then in addition to that, we are continuing to think about our state planning grant application. We're pursuing the health home model. And so our next steps are to develop a work plan, and then of course to continue to engage with our partners, because our stakeholders are very important to us.
Excellent.
Jeff, let's go to Florida. Emma, can you tell us a little bit about this? I had an email exchange with Jeff Brosco a week or so ago, so I'd love to hear where things are at.
Sure. So it is a slow roll, but it is rolling. And we will have a pilot with one of our payers and a small subgroup of patients that we currently share, just really trying to shift the way that care coordination is being provided on the payer side with our group. And one of the big discussions as far as next steps for Florida was the patient voices, patient and family voices. We know we have a lot of them, but kind of harnessing that power and finding a way to get that up to the payers and then our system, as well as getting creative with funding. We've asked a lot of our system for the past year or so in starting our small clinic, and I think it's time to get a little more creative with our funding.
Thank you, and we'll look forward to hearing how that goes. So I think we're just about ready to close this Academy session. You'll notice that our wonderful coordinator of the Academy, Erica Norcus, has put the link in for the evaluation. Please, we appreciate feedback on how these sessions are. Meg, are you still on? Did you want to offer some closing remarks?
Thanks, Rich. I'm here. I just wanted to say thank you to all of the presenters and the discussants for today's conversation. I also want to say thank you to all of the teams who are doing work on the ground with kids and families and clinicians. We have really had the opportunity in the context of the Care Coordination Academy to learn so much in so many different domains, not just around care coordination models, but things about financing, things about measurement, things about sustainability, things about family and professional partnership, things about communication, things about champions and advocacy, and how to get what you need for kids and families. And it's really been a wonderful learning experience for me and my team. And I'm hopeful that folks are getting similar benefit from the participation. We would very much like it if you told us about your experience in the context of the evaluation. Please take just a few minutes to fill that out for us now. Don't think to come back to it later because you might forget. We really do use that information to improve over time. So your input is really valuable and meaningful to us. So thank you, Heather, for popping that link in again. Now that I've plugged the evaluation, I'm going to turn the floor back over to Rich. Thank you all.
Thank you, Megan. I'm going to let Heather close us out, but as always, I want to express my deep gratitude to Erica Norkis, the coordinator of the Academy, to Heather, who's manager of the Academy, to Jessica Flaherty, who is Heather's colleague that really keeps the trains of the Academy running, to Beth Lynn, Virgo Houlihan, and Meg Hamo from the BU team, to Steve Fitton and Renee Turchi, and to Jeff Schiff and Mary Jo Palladino from our Family Voices, the core leadership team of the Academy. So we've got a couple of other sessions to get ready for and lots of work to be done. Heather, I'll hand it back to you and you can close us out.
Thank you, Rich. I want to echo everyone's gratitude. Today was wonderful. Please fill out the evaluation so we can continue to improve. I will send out the attendance link and the evaluation link in an email later today. As I mentioned before, if you have any difficulty with Google Docs, if your facility doesn't allow you to access that, just go ahead and email me. And you only need to fill out the attendance sheet if you are one of the approved professions for CEUs. Otherwise, if there's any questions or concerns that come up, I'm happy to help answer anything. And the content from today's event will be uploaded to Open Pediatrics by the end of the week, potentially sooner. So can go there and look things up, and anything, reach out to me. We will see you all on March 22nd. So be on the lookout for our next agenda and plans for then. Thank you all so much. It was great to see you.